going to start the complete revision series of our higher mental functions physiology. So first we need to start with limbic system and hypothalamus today. So first one is limbic system. So actually what is limbic system? Limbus is actually a rim of cortical tissue. So actually a rim of cortical tissue which looks like this, and it's old in evolution and it's mainly concerned with smell. So it was also called as rhinencephalon or smell brain because it's concerned with smell. It is called as rhinencephalon or smell brain. Let us see what are the main components of this limbic cortex. So mainly limbic cortex has three important constituents, that is hippocampus, amygdala and hypothalamus. So you can remember like hippocampus, amygdala, hypothalamus. So hippocampus is mainly associated with memory and amygdala with emotions, and we know about our hypothalamus which produce especially the posterior pituitary hormones like ADH and vasopressin. Now let us see ADH, oxytocin. Now let us see what are the functions of this limbic system. Mainly they are concerned with memory and emotions. Of course, memory by hippocampus and emotions by amygdala. So the functions are mainly regulated one important circuit that is called Papez circuit. So Papez circuit, what are its components? Let us check out. The first component is cingulate cortex. So from the cingulate cortex it reaches to hippocampus, and from the hippocampus to the mammillary bodies by means of fornix. The information goes to hypothalamus. From here finally it will reach the anterior nucleus of thalamus. It's actually about what this information is about, either memory or emotion. So these are carried from the cingulate cortex to the hippocampus, from the hippocampus by means of fornix to the mammillary bodies, that is hypothalamus, and from the hypothalamus to the anterior nucleus of thalamus. So this is called as Papez circuit. Now let us see, you can see here like in hypothalamus we have many nuclei, and the main thing is which nuclei produces which kind of effect that we need to see. So let us see the functions. The first one is circadian rhythm. So circadian rhythm is nothing but for the 24-hour, it's actually a 24-hour cycle. So let us see what it is. It's mainly regulated by suprachiasmatic nucleus. So here you can see in the diagram the suprachiasmatic nucleus, which is also called as master clock, and this regulates the 24-hour cycle of our circadian rhythm. And we have the ACTH, which is, in this circadian rhythm is nothing but it controls some hormones. Like for example, you can take here adrenocorticotropic hormone. It is highest in our body at the time of 5 a.m. and still this ACTH is lowest at the time of 3 p.m. So according to the timings of our body, also different hormones have highest peak values and lowest volume. Now let us see the regular food intake. So food intake is also one of the function of hypothalamus. So you can see hypothalamus controls the circadian rhythm, at the same time it also controls regular food intake, that is increased food intake. If you eating more, it is because of the lateral nucleus of hypothalamus, which is a feeding center. Lateral nucleus of hypothalamus. So remember lateral nucleus of hypothalamus for the food intake, and we have a neurotransmitter called orexin. Orexin is one where all substances increasing food intake called orexinergic. Means orexin is actually a neurotransmitter which increases food intake. So any lesions here, it will cause reduced food intake. So if there is any lesion in orexin, it will lead to decrease in food intake. Now let us see the decreased food intake center, that is a satiety center, which is a ventromedial nucleus. So you can see this is a ventromedial nucleus of hypothalamus, which is concerned with satiety. And the lesion here, of course, it is controlling to decrease the food intake. But if any lesion, it will be reversed, that is the person will eat more food. So remember, hypothalamus have mainly three nucleus which are related with three functions. One is circadian rhythm by suprachiasmatic nucleus, and higher food intake by orexin neurotransmitter, and which is present in our lateral nucleus of hypothalamus. And the ventromedial nucleus of hypothalamus is for satiety. So for over food intake, lateral nucleus of hypothalamus. For less food intake, ventromedial nucleus of hypothalamus. And for circadian rhythms, we have suprachiasmatic nucleus. Three important nucleus of hypothalamus concerned with three functions. So very important about this. Next, let us move on to arcuate nucleus. So arcuate nucleus is also present in hypothalamus. So what it does, let us see. Mainly it is divided into, you can see, lateral nucleus and stimulate the ventromedial nucleus. So what happens in ventromedial nucleus and lateral nucleus? Already we discussed before. In the lateral nucleus, it increased food intake. Ventromedial nucleus decreased food intake. But what about arcuate nucleus? Let us see. Here we have in the lateral nucleus AGRP, that is agouti gene related peptide, which is a neuropeptide. Why? Yeah, of course, increase the food intake. Same. We have seen before lateral nucleus increase food intake, but now we are seeing by which mechanism? That is mainly by this agouti gene related peptide, that is neuropeptide Y. So this neuropeptide Y is useful to increase in food intake, whereas this ventromedial nucleus stimulated by. So actually what they are saying is arcuate nucleus also have association with this food intake and satiety center. Arcuate nucleus can stimulate either ventromedial nucleus and lateral nucleus. So if arcuate nucleus stimulates the lateral nucleus, there will be higher food intake, whereas if the arcuate nucleus stimulates the ventromedial nucleus, it will lead to satiety. So what is the mechanism for satiety is the alpha MSH is released by ventromedial nucleus, that is the alpha melanocyte stimulating hormone, and also cocaine amphetamine regulated transcript. So because of these two chemicals, it will lead to satiety. So higher food intake by neuropeptide Y, satiety by CART and alpha MSH. So now let us see next one, that is the regulation of body temperature, and hot environment activates anterior-medial nucleus. So you can see here hot according to temperature also our hypothalamus regulates the body temperature by certain nucleus. So we have anterior nucleus, which leads to sweating, vasodilation and thirst, especially whenever there is heat and hot environment. So in hot environment, anterior nucleus is activated. It will lead to sweating, vasodilation. Why vasodilation? More blood flow so that we can feel cooler, and also it will activate the thirst center in our hypothalamus. So if any lesion in this area, of course it will cause hyperthermia, because these mechanisms are lost now. So because of this, if there is more hotter temperature, we feel more heat, that is hyperthermia. Now let us see in cold temperature how hypothalamus reacts. In cold temperature, hypothalamus activate posterior nuclei, of course opposite. So whenever there is hot temperature, anterior nucleus is activated. Whenever there is cool temperature, mainly due to shivering, vasoconstriction and also increased urine frequency. Why shivering? Shivering to protect from the cold, so that more heat can be generated. Vasoconstriction, because now blood vessel is narrow, so that only low blood flow to the periphery, so more heat is concerned, and also increased urine frequency. So if any lesion here, it will lead to hypothermia, that is we feel more cool whenever any lesion in the posterior nucleus. Now let us move on to the regulation of sleep and wakefulness. So how sleep and wake cycles are regulated? So mainly they are by lateral nuclei. Already we have seen lateral nuclei also used to increase the food intake, and lateral nuclei also take its function in sleep and wakefulness. So here the neurotransmitter is orexin, which is a arousal neurotransmitter. Of course, orexin is also increasing the food intake. And the posterior hypothalamus secretes a neurotransmitter histamine. So by secretion of histamine by posterior hypothalamus, it will also lead to induces sleep and wakefulness. And sleep, we have sleep center, especially in preoptic nuclei, especially in the ventrolateral side. So sleep center is in the preoptic nuclei of a hypothalamus. So this is how the sleep and wakefulness are regulated, mainly by lateral nuclei. So lateral nuclei two functions: increase food intake and also lead to sleep and wakefulness cycle. Next, let us see role in memory. So mainly we have mammillary bodies which are also present in a Pepys circle. It's a component of Pepys circle, we know mammillary bodies. So they degenerate. If there is any degeneration of mammillary body, then Wernicke's Karpov is in chronic alcoholism. Like in that, people will see ataxia, some confusion, and also memory loss, that is confabulation. So mammillary body is very important for the memory. So if any loss in memory means any degeneration in mammillary body, of course it will lead to Wernicke's-Korsakoff, especially in chronic alcoholism, ataxia, confusion, memory loss, confabulation. Now let us see what is the regulation of endocrine hormone secretion. Hypothalamus produce mainly a releasing hormone and also inhibitory hormone. So for example, releasing hormones are like thyroid stimulating hormone, adrenocorticoid releasing hormone, we know this. Inhibitory hormones, like in the case of prolactin, growth hormone, they are inhibitory hormones, right? So regulation of endocrine hormone either by releasing factor or inhibiting factor. So next one is synthesis of vasopressin oxytocin. We already discussed in endocrine physiology. Vasopressin is coming from supraoptic nucleus, oxytocin from paraventricular nucleus. They are stored especially in the posterior pituitary. So posterior pituitary don't produce the hormones, it is just stored here. Hypothalamus produces hormones and releases it by means of a vessel. and they come to the posterior pituitary and get secreted out. So next let us see the stimulation of dorsomedial nucleus. So dorsomedial nucleus stimulation will lead to aggression, especially in cats. We have seen this where there is sham rage phenomenon, that is hissing, biting, and increased blood pressure is seen here. With EEG and sleep. So EEG is what? It's a electroencephalograph. So actually it represents the overall electrical activity of a brain, which is a very keyword is overall. It's not about a single activity of a brain. It connects the overall activity of a brain, and it is mainly seen in the form of summated potential. That's what we are saying, overall activity of the brain. So it's in a summated potential, that is sum of all potentials of a brain. So mainly it was first found out by a psychiatrist, that is Hans Berger, and this Hans Berger is the first one who have recorded this EEG. And what is the frequency? Here the frequency is the number of waves per second. Actually here the waves are formed in an electroencephalogram, so that number of waves per 1 second is called frequency. And this frequency is directly proportional to the activity of the brain. Like if the frequency is higher, if the brain activity is higher, then we'll have more number of frequency. So like that we can measure this frequency and activity of brain. And the EEG records are like 5 brain waves. So mainly we have divided the EEG brain waves into 5 major brain waves. So what are those waves called, and what are the frequency? Let us find out. So EEG wave, the first one is a gamma wave. The gamma wave is having a highest frequency. You can see it's greater than 60 Hz. The frequency is greater than 60 Hz. That is a gamma wave. Next you have the beta waves. Beta waves are having a frequency of 13 to 30 Hz. So in between 30, its ranges between 13 to 30 Hz. And next you have the alpha waves, which are very important waves. Its frequency is like 8 to 12 Hz. And next you have the theta waves. Its frequency is 4 to 7 Hz. And next you have delta waves, which are the slow waves. And so you can see at the word slow waves, so the frequency is very low, like 1 to 3 Hz. It's the lowest frequency among all this waves. So the highest frequency wave is gamma wave. The lowest frequency wave is delta wave. We can remember this like lower form, like 1 to 3 first, next 4 to 7, next 8 to 12, next 13 to 30, next above 60. You can see this is the next number. First 1 to 3, next after 3 4, 4 to 7, next after 7 8, 8 to 12, next after 12 13, 13 to 30, and greater than 60. So this is how we can remember these waves. Next let us see the waves of EEG. So mainly we'll discuss now each of this wave in somewhat detail. So first we'll see, as I said, alpha wave is very important. So we'll see the alpha wave. So alpha wave actually a wave of inattention. Inattention means now the person, for example, you are listening this video but you are thinking about something else. Then it is a wave of inattention. Now in your brain you will have the alpha wave. It is generated mainly from occipital and parietal cortex. So it's mainly coming from back occipital and the parietal, the lateral sides of our brain. So this is mainly a wave of inattention and seen in a non-sleeping person. Here you may think that if it is inattention means the person is not sleeping. The person is sleeping, but the person is not sleeping here, but the eyes are closed. Just you are in a relaxed stage, you are closing your eyes and thinking about something but not giving attention to the surroundings. That is alpha. At that time we can get the alpha waves. So the mind is wandering somewhere, and the frequency already we have discussed 8 to 12 Hz of a alpha wave. And next we'll see the what are beta waves. So beta wave is actually a wave of attention or wakefulness. So if you have a lot of attention now, if you're listening to this video with attention, that is a beta wave, and the frequency is 13 to 30 Hz, and it is mainly generated from frontal cortex, that is a prefrontal cortex. So mainly prefrontal cortex, your brain is having attention now, that is a beta wave, and the frequency already discussed 13 to 30 Hz. Next we'll see the theta waves. So theta waves are mainly the memory waves, that is generated from the hippocampus, and it is generated, of course we already discussed in previous video, hippocampus is associated with memory. So memory waves are nothing but coming from hippocampus, generated during conversion of short-term memory to long-term memory. That is converting the short-term memory to long-term memory, which lies forever in our brain. So this conversion is going on at that time. The theta waves are formed. So theta waves are like when we are writing any exam, or like we are recollecting everything at that time. So that is a theta wave is formed then. So the frequency is here like 4 to 7 as we already discussed. So these are also seen during sleep. Remember, theta waves are also seen during sleep. Next let us see the delta waves, are the slow waves and major sleep wave. as a slow, it's major sleep wave, especially in non-REM sleep. So here exclusively generated during sleep, and the frequency is like 1 to 3 hertz slow waves. So next comes the gamma waves, the highest frequency waves. These are mainly generated during focus attention, like frequency of 60 hertz. So kind of very focus attention, not like listening videos, but in exams we have a lot of focus attention. So that time we have gamma waves, which is greater than 60 hertz. So we discussed the types of waves and their characteristics. Now let us see about sleep. So mainly sleep is divided into two types. It's also a brain activity. First one is non-rapid eye movement. In the name itself you can see here the eye is not moving but you are in sleep. But the next one is REM, that is rapid eye movement. Here eye is continuously moving. So let us see about this two types of sleep. Let us understand a very interesting topic about sleep. So first one is non-REM sleep, non-rapid eye movement sleep, and its stages. So mainly we have 4 stages in it, and we have new nomenclature, and also we have frequency of them again. So stage 1 is mainly as N1, and it's 4 to 7 hertz. So you can see 4 to 7 hertz means it's similar to theta wave, so it's a theta wave. So stage 1 of non-REM sleep is associated with the theta wave. We already discussed theta wave. These are also seen during sleep, especially what sleep. Now you can write here non-REM sleep stage 1. Especially in stage 1 you will see this theta waves. Next stage 2, it's called N2. Here the frequency is 8 to 12. You can see it's relating with alpha waves, but they are not alpha waves. That's very important point. You are seeing, like, now we are comparing the frequency of the EEG with the sleep. In the stage 1 we have found the frequency of 4 to 7, which is similar to theta wave, and yes, and as it's a theta wave. But the stage 2 N2, it's like an alpha wave. The frequency is like alpha wave, but it is not an alpha wave. And here instead of alpha wave we'll see the sleep spindles and K complexes. Very important point. So stage 2 N2, it's not an alpha wave, but here we can see the sleep spindles and K complexes. Next let us see stage 3 and 4, why they are together, and they're called as N3. It's like 1 to 3 hertz, and it's similar to the delta waves. You can see slow waves, and it's a delta wave also. It's a slow wave, major waves of non-REM sleep, slow wave sleep. Already in delta wave seen slow REM major sleep wave, and which stage also you can mention here, like 3 and 4. So this is exclusively generated, delta wave is exclusively generated at the sleep. So it's a major slow sleep wave. Now let us see the REM sleep. So we have associated the non-REM sleep with the EEG waves and their frequency. Now let us see what is there in REM sleep. So REM sleep is a rapid eye movement sleep. So here we have PGO spikes, which are responsible for eyeball movements in a REM sleep. So the wave of REM sleep is mainly beta wave, the wave of wakefulness. So in an EEG you have seen many waves associated here. In a non-REM sleep, like theta wave is associated, delta wave is associated, right? Theta wave, delta wave, but the beta wave is not associated here, right? So the beta waves comes here in the REM sleep. In the REM sleep mainly we have beta waves association, but you can think that beta waves said whenever we are having focus attention, means normal attention, right? So whenever in attention you have beta waves, but here you can see in REM sleep we are sleeping. In sleeping what attention we have? That's why this kind of sleep is also called as paradoxical sleep. And the impulse generated first in the pons, and from there it reaches the lateral geniculate body. From the lateral geniculate body it ends in the occipital cortex. So finally it reaches the occipital cortex. So this is about REM sleep. Now we'll check out the physiological changes during sleep, like what are the physiology behind the sleep. So what happens mainly during non-REM sleep? We will discuss non-REM sleep is associated with theta waves and delta waves, right? Especially theta wave with stage 2 sleep, and delta wave with stage 3 and 4 sleep, and REM sleep is associated with beta wave. So it's like just a small recall. So now you see during non-REM sleep there is decrease in blood pressure, there is decrease in heart rate, and also body temperature. So you can see everything is decreased in non-REM sleep, and the respiration is also very slow and deep. Whereas in a REM sleep you see all muscles undergo atonia. Like some persons you see if they're sleeping, they fall, like suddenly they fall on us because they don't know what their muscles are atonia at that time. So except diaphragm and extraocular muscle, very important. Diaphragm and extraocular muscles are not in atonia in a REM sleep, and it's leading to fall asleep. It's like very sleepy condition, and here mainly we'll see in males penile enlargement and also there is a sexual arousal in both sexes. So this is about REM sleep. Now let us see the hormonal changes during sleep. What hormones will rise and what happens? Let us see. So mainly the growth hormone. The growth hormone level rises especially in non-REM stage like 3 and 4. In 3 and 4 we are discussed already. We have what kind of wave? We have delta wave, which is a slow wave. At that time the growth hormone level is very high. And the prolactin level also rises especially during REM sleep, that is beta wave, right? And around the puberty there is nocturnal rise in luteinizing hormone. And in the pineal gland, the melatonin level rises, which is including the sleep. So these are all the different hormonal changes going on in the sleep. And next let us see the dream and non-REM sleep and REM cycle. So mainly dream is coming in both non-REM sleep and also in REM cycle. So let us see what kinds of dreams are coming in REM sleep and non-REM sleep. So dream is common both during the REM sleep and non-REM sleep. And the dreams in REM sleep are mainly long duration, and there are emotional dreams and not related to day-to-day activities. So very important, emotional dreams, long duration dreams, and not related to any day-to-day activities. But the dreams coming to the non-REM sleep are mainly of short duration, conceptual dreams, and related to day-to-day events. So if there is any concept, means it is related to day-to-day events. If there is any emotion, means it's not related to day-to-day events. And this is a long duration dream, this is a short duration dream. Let us see the non-REM and REM cycle. So one cycle is actually having 90 minutes, means in every sleep we are having 90-minute cycle. It's called as ultradian rhythm. So actually we see circadian rhythm, which is of 24 hours, whereas ultradian rhythm is 90 minutes. It's a cycle that fluctuates around 90 minutes. In a sleep of 8 hours, in a complete sleep of 8 hours, maximum 45% sleep is spent in non-REM stage 2, especially stage 2, that is the theta waves, and in non-REM stage 1 also. So 5% in non-REM stage 1, almost 45% in non-REM stage 2. Let us see the regulation of sleep and its area, its neurotransmitter. So reticular activating system mainly release a norepinephrine. This is useful arousal. So when you are in awake stage, you have more norepinephrine, or for arousal we need norepinephrine. And from the lateral hypothalamus you have orexin, hypocretin. It is also useful for arousal. So any mutation in this orexin, it will lead to narcolepsy, like a person will be sleeping in between and also he'll have morning sleepiness, because night also can't sleep very well, because sometime he'll sleep again wake up, sometime he'll sleep again wake up. So any abnormality, mutation in orexin will lead to narcolepsy. So this orexin, hypocretin are also arousal neurotransmitter. And posterior hypothalamus release the histamine, which is also an arousal neurotransmitter. And you have a raphe nuclei which secrete the serotonin. It's mainly for sleeping. So only we have one nuclei for sleep, and all the remaining one are mainly decrease in sleep, because they are all leading to arousal. So note that the neurotransmitter of arousal are norepinephrine, orexin, histamine. Orexin is also called as hypocretin. So they mainly decreases during the sleep. Next let us see the sleep promoting areas. So you can see the sleep promoting areas. You have hypothalamus, it has a sleep center, that is a ventrolateral preoptic nucleus, which is a sleep center. And in the pineal gland we have the melatonin receptor agonist. We also have remelton, which is responsible for jet lag syndrome. So the people who are like coming from different countries, they have different timings, so because the sleep cycle is disturbed, so to prevent that we can use a treatment of remelton, which is an agonist of a melatonin receptor. And next we have an cholinergic neuron. So cholinergic neuron, it releases mainly acetylcholine as a neurotransmitter, and it induces a REM sleep. So for the REM sleep, acetylcholine is required. So this cholinergic neuron is mainly in the region of pons or midbrain, and this releases acetylcholine. This is also called as Remon neuron, because it induces a REM sleep, especially by acetylcholine. Next let us see the events occurring during sleep parasomnias. So actually this is during non-REM sleep. So like in non-REM sleep only the people who have some disorders, and also in REM sleep they have some disorders. So let us check out what are the difference between disorders in non-REM and REM sleep. So non-REM sleep disorders are like sleepwalking. Some people walk in sleep. That is called as somnambulism, and it's mainly seen in stage 3 and 4 of a non-REM sleep. So stage 3 and 4 of a non-REM sleep means it's actually delta waves, the slowest wave. And in sleep talking, some people talk in sleep. And teeth grinding, especially is called sleep bruxism, seen in infants who are having some disorders, depression disorders, teeth grinding. It is seen in especially non-REM sleep stage 2. And nocturnal enuresis, there is some people, small children have bedwetting problem. So these are all sleep disorders which are seen during non-REM sleep. And night tremors are also seen in non-REM sleep, that is called as power nocturnus. Like night tremors, they have some dreams, terrors dreams. And it's coming to the during the REM sleep. During the REM sleep, the people we have nightmares and also narcolepsy. We already discussed narcolepsy due to the mutation of orexin. So orexin mutation will lead to narcolepsy, where people will have in between sleep and they will have morning drowsiness, that is narcolepsy. So seen during REM sleep. So this is all about the sleep and our EEG physiology. Next we'll move on to learning and memory. Learning and memory. So learning and memory is main function of a dominant hemisphere. So what is this dominant and non-dominant hemisphere? Let us understand. So mainly the left hemisphere is called as dominant hemisphere and the right hemisphere is called non-dominant hemisphere. So we have seen here the learning and memory is a function of dominant hemisphere, means the learning and memory is the main function of the left hemisphere of a left cerebral hemisphere. So this left hemisphere is also called as categorical hemisphere. And 96% of the people who are right-handed and 70% of the people who are left-handed, mainly their dominant hemisphere is a left hemisphere. And main function of this left hemisphere is for language, for memory, for logic-based reasoning. So if there is any lesion in it, it is called as aphasia. And right hemisphere is called as non-dominant hemisphere, and this is also called as representative hemisphere. That is, it has a special space orientation and intuition based thinking, creativity, musical skills. So all these are associated with this right hemisphere. Mainly left hemisphere for memory and language and logic, all this learning, but the right hemisphere is for some intuition thinking, creativity, musical skills. So if there is any lesion in right hemisphere, it's called hemispatial neglect, or it is also called as asteriognosis. So asteriognosis and hemispatial neglect is seen mainly in the lesions of non-dominant hemisphere. Hemispatial neglect means a person only shaves one side of his face like that, so he will neglect the other side of the face. So this is about a right hemisphere lesions. Now let us see the learning and memory, and what is this explicit memory. So learning is mainly a process of acquiring the information, but memory is a storage of information. So first if you acquire, that is learning. Next if you store it for longer time or short time, that is called memory. So what is explicit memory? Explicit memory is also called as conscious or declarative memory. So it's conscious, your memory is conscious, and it's also declarative. So you can see here the explicit memory is conscious, means you are conscious when you are thinking about it and when you are remembering about this. So it's also called as declarative memory. So it's mainly for remembering either places or different faces. So it's called semantic, like it's cemented. You can remember, like it's cemented in your brain. Like you'll see different places, you will remember that name. You'll see different face, you can identify that this face is this name, like that. So these are all declarative and conscious memory. So the events are episodic, like at that episode what happened, at that time what happened. So these are the events which are episodic memory. So you can see the explicit memory is called conscious and declarative memory, and this is in turn divided into semantic memory and episodic memory. Semantic memory is where places, faces are remembered, and episodic memory is where the events are associated. So the main area for this explicit declarative memory is a hippocampus. Of course, whenever memory comes, hippocampus is a major one, and also the important one to remember is here the medial temporal lobe. Very important, medial temporal lobe. So along with hippocampus, the medial temporal lobe is used for either semantic memory or episodic memory, which is nothing but our conscious and declarative memory. Especially the heading is explicit memory. So the keywords here you need to remember as explicit memory, declarative memory, conscious memory. It's divided into semantic memory and episodic memory. Semantic memory with faces, places, and episodic memory with the events. Now let us see, and the area is of course hippocampus and medial temporal lobe. Let us see implicit memory. So it's also called as subconscious, like you are not conscious here, and non-declarative, it's not declaring also. Means it's not in your you'll do it like an habit, it's like a habit. So the procedure and skills memory, like example basal ganglia striatum. So procedures and skill, like for example you learn car driving. At the beginning the car driving is for you an explicit memory, like at the beginning you will full focus on it, like which you are holding the brake or like that, but later implicit memory, it will become a habit, like with even when you're talking, even when you are listening to the songs, you can drive the car. So that is an implicit memory, it's a non-declarative subconscious memory. So like procedures, skill memory, especially it's by control of basal ganglia striatum. And the primary memory is by neocortex. The first words can only guess the color. For example, if I'm writing blue, and next I write, so you can say just gr by only can say the next word is I'm going to write green. So like you have understood that I'm going to write the colors. So just by the starting initial words only you can say the full one. That is mainly because of neocortex, that is a primary memory. And the conditioning memory. Conditioning memory is by amygdala and cerebellum. So conditioning, for example, Ivan Pavlov experiment he did on dog when he rang the bell along with the food and repeated times, then even by bell rang only the dog is salivating. So it's like conditioning. So this is a main function of amygdala cerebellum. So here the keywords: implicit memory is non-declarative and it's not conscious, that is nothing but subconscious. And here the procedures and skill memory by basal ganglia striatum, and the primary memory neocortex, and next conditional memory by amygdala and cerebellum. Next, coming to synaptic plasticity. So what is this? The basis of memory is synaptic plasticity. It's repeated stimulation of synapse can increase the response or either decrease the response. So what is this is? For example, if you are revising anything for a long time, you can easily recall it. But if you revise only for a few times, it will not. Why? By revising more times, the synapse is more strengthened and more synapse is going on. So let us see how there is increase in response. So there is PostTetanic potentiation, long-term potentiation, especially in hippocampus, it will lead to sensitization. Whereas decreased response is long-term depression in cerebellum, that is habituation. So remember, decrease in response is habituation, increase in response is sensitization. Now let us see some important points about hippocampus. So mainly we have CA1 neurons which are present, which converts the short-term memory to long-term memory. So CA1 neurons play an important term to convert short-term memory into long-term memory. And the CA1 neurons are also called memory neurons because they are converting into long-term memory. The sensory input are mainly coming from the CA1 neurons enter either into these two pathways, that is the efferent or perforant pathways, that is either a direct pathway or indirect pathway. So direct pathway first goes into entorhinal cortex, it's a component of limbic system and directly activates the CA1 neurons. Or indirect pathway, again of course the starting point is entorhinal cortex, it gets activated and activates the dentate part of hippocampus. Here in turn the CA3 neuron gets activated and this CA3 neuron activates the CA1 neurons. This is called Schaffer collateral. So between the CA3 and CA1 we have the Schaffer collateral. So you can see directly the CA1 is activated here, but first here the CA3 is activated, later the CA1. So it's indirect pathway. So however the CA1 is activated, then it will lead to conversion of short-term memory to long-term memory. From beginning of this revision series we are saying hippocampus is a main fun for the memory. How? That is because of activation of CA1 neurons. So only on repeated activation of synapse short term will be converted into long term memory, and this is called consolidation of memory. Even consolidation of memory is in hippocampus. So hippocampus, you should remember in hippocampus mainly C word because it has CA1 neurons, it has consolidation of memory, everything is with C. Even in indirect pathway you have CA3, later it will activate CA1. So consolidation of memory or long-term potentiation, mainly CA1 neurons. So this is about hippocampus. Now let us see about our long-term potentiation. So actually it's in a disordered page, but I'm trying to explain it here. So long-term potentiation is nothing but synaptic strengthening. Like if you want to remember anything for a long time, then you should have synaptic strengthening. That is, you can see here, on repeated activation of CA1 neurons, the stored glutamate is released and it acts on NMDA receptor, and later it will lead to NMDA receptor, and because of this NMDA receptor is present on postsynaptic membrane. On presynaptic membrane the glutamate is released, and by release of this glutamate, it will reach the NMDA receptor which is present on postsynaptic membrane, and by calcium influx inside the postsynaptic membrane, it activates the second messenger system, that is mainly producing proteins and strengthens the synapse. So this is the main mechanism behind your revision. If you do more revisions, it will be in the long-term memory by this strengthening of synapse. So the same mechanism is here. You can see CA1 neuron. Before we have said the CA1 neuron is stimulated by hippocampus, and by repeated activation the glutamate is released on the postsynaptic membrane. The NMDA receptor will receive this glutamate. Because of this, there will be calcium influx and more proteins are released and strengthen the synapse. So let us see how it is clinically correlated. So the clinical correlation is CA1 neurons mainly belong to the soma sector. So actually there is some sector called soma sector. So the CA1 neurons belong to soma sector. So any lesion in the soma sector, the CA1 neurons are first affected and the memory conversion is affected. So soma sector lesions will lead to memory problems. So the clinical features is procedural and skill memories are intact. So like which are your habits, all those memories will be intact, but no new memory formation. That is called anterograde amnesia. Anterograde amnesia means we have all the memory till now what we have learned, but we are no more able to learn the new memory and convert the short-term memory to long-term memory. That is called anterograde amnesia. So anterograde amnesia is a problem in hippocampus. So it's mainly because of CA1 neurons, that is belonging to soma sector lesions. So any lesions, any abnormalities in soma sector, it will lead to anterograde amnesia, where you are no more able to learn the new information and you are not able to convert the short-term memory to long-term memory. And mainly the procedural and skill memories are still intact, like driving, swimming, all those can be done, but only the information cannot be remembered in this person. So next let us see the long-term depression. So long-term depression is seen at the level of cerebellum due to synaptic weakening. So if any synapse is weak, then it will lead to long-term depression, and it is also a type of memory weakness, faulty synapses. So next let us see speech. Speech, there are 4 brain areas involved in speech. So the first is Broca's area, next is Wernicke's area, next is Arcuata fasciculus, and next is angular gyrus. So what happens in these 4 brain parts? Let us check out the location. The Broca's area is in inferior frontal cortex, Wernicke's area is in superior temporal gyrus, and angular gyrus is mainly corresponding to Broca's area number 39. So what are the functions of Broca's area? Mainly for the motor speech or area of speech output, or also called as input or vocalization. And the Wernicke's area main function is sensory speech area, where there is comprehension and understanding. So mainly in the Wernicke's area, the person will understand and comprehend the things, whereas in Broca's area there is vocalization, the speech is coming out. And the arcuate fasciculus connects the Broca's to Wernicke's. So to connect the Broca's to Wernicke's area, we have arcuate fasciculus. And angular gyrus is mainly connects the visual information area to speech area. So whatever you are seeing, if you want to talk about it, then that visual information should be connected to the speech area mainly by angular gyrus, that is in the area number 39 in a Brodmann's classification. So next, coming to the lesions. So if there is any lesion in Broca area, what happens? Then the Broca aphasia. Broca aphasia is speech output is reduced, non-fluent aphasia. So actually here what happens, a person can understand what you are saying, but he can't speak it out. That is called Broca's aphasia. And next, coming to Wernicke's aphasia, like Wernicke's lesion. This is called sensory aphasia. It is a comprehension impaired but fluent aphasia. Like what happens here is, the person what you are saying, he can understand that, but he can't speak it out. So that is called so he can't understand anything here. Wernicke's aphasia means sensory aphasia, comprehension impaired. The person can't understand, but he speaks something. For example, if you ask what is his name, he says like apple. So that is Wernicke's area. He can't understand what you are saying. And Broca's area is speech output is reduced, means he can can't speak it out. He can understand the things, but he can't speak it out. Here he can't understand and he can speak out. And next, coming to arcuate fasciculations, here it's called conduction aphasia. And in angular gyrus lesion, it will lead to anomic aphasia. So here we have presilin 2 or 1 mutation. It will lead to amyloid precursor protein gene mutations. So this is one more important point from the bits. So that's it. By this we complete our learning and memory. Next we'll move on to CSF and cerebral blood flow and blood-brain barrier. Start with CSF, cerebral blood flow and blood-brain barrier. So mainly the fluids in central nervous system are useful for lubrication and protection. The main one is our cerebrospinal fluid, and for the nutrition we need the cerebral blood flow. So in CSF, the normal values of the CSF is 150 milliliter, and the rate of production of CSF per 1 day is 550 milliliter, and the recycling which is going on is like 3.7 times per the day. And the normal CSF pressure is 70 to 180 millimeters of water, and the site of production is choroid plexus, and the site of absorption is arachnoid villi, and the regulation of CSF occurs at the level of absorption, that is at the arachnoid villi. So these are all the important points first we need to understand in the CSF, and later you can see this the plasma values of the sodium, all these ions in plasma and the CSF. We are comparing it. Let us see which is higher, which is lowest. So here you can check out compared to the plasma, the CSF has highest concentration of chlorine, magnesium and partial pressure of carbon dioxide, very important. So compared to plasma, CSF only have higher concentration of chlorine, magnesium and partial pressure of carbon dioxide, and the equal concentration of osmolality bicarbonate ions. So like plasma and CSF have equal osmolality and bicarbonate ions, but there is low concentration of glucose in the CSF. CSF glucose is 2/3 of plasma glucose, and even the proteins in the CSF are low, in the potassium and calcium in the CSF are also low, but the higher concentration in CSF is chlorine, magnesium and partial pressure of carbon dioxide. Osmolality and the bicarbonate ions are equal along with the plasma. And next, beta-2 transferrin is present only in CSF, and it is used as a CSF marker mainly to diagnose the CSF rhinorrhea and also CSF otorrhea. So these are diagnosed by CSF marker beta transferrin, which is present only in CSF. Next, let us see the cerebral blood flow. The main source is of course the circle of Willis. The normal cerebral blood flow is like 750 milliliter per minute or 55 milliliter per 100 gram per minute. So it's like half of liver blood flow. Liver blood flow is like 1500 milliliter per minute, but the half is 55 milliliter per 100 grams. That is a normal cerebral blood flow. So gray matter receives the more blood supply than the areas of white matter. Very important. Gray matter have more blood supply than white matter. The oxygen consumption by brain is 96 milliliter per minute. That is 20% of total body oxygen consumption. And the brain is highly sensitive to hypoxia, that is whenever there is low oxygen, it's more sensitive. Most sensitive part is especially hippocampus. So hippocampus is more sensitive to hypoxia. And regulation of cerebral blood flow. The blood pressure, whenever the blood pressure fluctuations like are between 65 to 140 millimeters of mercury, there is no change in cerebral blood flow because of autoregulation. That is the brain itself have its autoregulation process. It will check out the blood pressure whenever the blood pressure is dropping. And the partial pressure of carbon dioxide is also high. It leads to high, like whenever there is higher partial pressure of carbon dioxide, then even the cerebral blood flow will increase. And the temperature, when the body temperature is lowered just by 1 degree, then the cerebral blood flow also will lower by 7%. So these are like associations of cerebral blood flow with either partial pressure of carbon dioxide with temperature. So you can say whenever the partial pressure of carbon dioxide is increasing, then cerebral blood flow also increases, and whenever the body temperature drop by 1 degree, then the cerebral blood flow also drop by 7%. And therefore hypothermia is induced in certain neurosurgical procedures to minimize the blood loss. So actually hypothermia is given in like some neurosurgical procedures because so that we can minimize the blood loss. And next, now we'll see our blood-brain barrier. So it's mainly formed by tight junctions and a food process of astrocytes. So the substances that can cross are lipid-soluble steroid hormones can cross blood-brain barrier. Gases like oxygen, carbon dioxide, nitrogen can cross. Glucose can cross by GLUT1 transport, and the water also can pass the blood-brain barrier mainly by aquaporin 4. So these are the 4 substances which can cross the blood-brain barriers. Now let us see what substances can't cross the blood-brain barrier, like water-soluble protein hormones, hydrogen ions, dopamine. Areas where blood-brain barrier is absent is, so these are the only 3 substances which can't cross, like dopamine, hydrogen ions, water soluble protein hormones. So dopamine can't cross. So for the treatment of Parkinson's disease, we give L-Dopa because dopamine can't cross the blood-brain barrier. And now let us see where there is no blood-brain barrier, especially in circumventricular organs. The mnemonic is like SOAP. So in the SOAP, there is no blood-brain barrier. S for subfornical organ in the SOAP, and O for organum vasculosum of lamina terminalis, also called OVLT. Area postrema, which include the vomiting, and posterior pituitary. So these are the 4 regions where there is no blood-brain barrier. Next, let us see the Monroe-Kelly doctrine. So what is this? At any point of time, the volume of CSF blood brain tissue should be constant. Always the volume is constant. If there is any change in one of the parameters, then the other 2 will be compressed. So as the volume is constant, so if there is any change in any parameter, of course it will be compressed. So for example, if the CSF pressure increases, then it will compress the tissue and also the blood flow. So CSF, blood and brain tissue are having the same volume. So if any change in either one of it, it will lead to compression of others, and it will, of course, it will lead to drop in blood flow. So this is all about CSF, blood-brain barrier, and also cerebral blood flow. By this, we have completed our complete revision series of higher mental functions.